I'm Dr. Mansoor Madani, Chairman, Department of Oral and Maxillofacial Surgery at Capital Health System in Trenton, New Jersey, and Associate Professor, Department of Oral and Maxillofacial Surgery at Temple University Hospital in Philadelphia, Pennsylvania, and Director of Bala Institute of Oral and Maxillofacial Surgery in Bala Cynwyd, Pennsylvania. I hope that by now you have listened to the other part of the adult and pediatric medical emergency. We discussed in previous lectures prevention, preparation, recognition, management of variety of conditions. The topic of today's presentation is asthma and allergy and autoimmunity. We start with a case, a 64-year-old man who comes to your office for extraction of several teeth and periodontal surgery. His blood pressure is 142/78, heart rate is 69. More importantly, he has a cardiac valve replacement requiring antibiotic prophylaxis. Unfortunately, however, he forgot to take his antibiotic prophylactic medication this morning. So you provided him with 4 capsules of amoxicillin as he had no history of allergic reaction. But as you wait to start his treatment, you notice few rashes on his face. A few minutes later, you notice that he starts itching his arm and chest. Swelling and rashes start to appear in those areas as well. He complains of shortness of breath, feeling of lightheadedness. He starts to cough with distinct wheezing and difficulty breathing with throat and chest tightness. Obviously, you would be suspicious of an allergic reaction, and that's your first line of thought. But you may also have a serious condition to deal with. What if the patient became confused, tachycardic, hypotensive, and then became unconscious? Remember, if severe reactions are not diagnosed and treated immediately and properly, it could have deadly consequences. For this reason, I want to discuss allergic reaction and immunological process that occur first, and then we will discuss the management of the patient. An additional note that I must stress, allergic reactions are not limited to any one's dental or medical practice. Our own families could be at risk of developing allergic reaction, and I encourage you to pay particular attention to this topic. In our daily practice, when we prescribe a medication, when we administer or inject local anesthetic or a sedative anesthetic, there is 1 to 3% chance of allergic reaction. To predict who is going to have an allergic reaction is difficult, but prompt recognition and correct treatment is necessary to assure a safe outcome. Allergic reactions can occur at any time during dental procedures. The ability to react and treat a patient who has experienced an allergic reaction is essential and even life-saving. This course will highlight allergic reaction that our patient may experience as a result of exposure to medication and material used during and after dental treatment. In some instances, the stress of being in a dental practice could set off reactions such as an asthmatic attack. The pathophysiological mechanism that occur during various allergic reactions, local and systemic manifestation, emergency medication, as well as appropriate treatment will be discussed. I have to stress again, as I have explained in detail in the other presentation, that prior to initiation of all dental procedure, a thorough medical history should be taken and updated regularly. The presence of systemic illness, current medications, adverse and allergic reactions to previous medications necessitate further investigation. An important point to remember is that an adverse reaction to a medication is not always an allergic reaction. An example of adverse reaction we very commonly see in our dental practices is the development of tachycardia after administration of local anesthetic and patients' perception that they are allergic to that agent. Here is when the practitioner should explore the exact nature of the reaction and treat the patient accordingly. In general population, allergic diseases are very common. According to the American Academy of Allergy, Asthma, and Immunology, an estimated 40 to 50 million Americans have at least one type of allergic diseases. Allergies are amongst the most common chronic conditions worldwide. The clinical manifestation of these reactions can range from a rash or urticaria, which we could see in nearly 50% of medication-related reaction, to a 1% incidence of much more serious and life-threatening conditions such as generalized anaphylaxis, which we suspect our first patient had. Nearly 82,000 episodes of anaphylaxis may occur each year in the United States. Allergic diseases are considered to be the sixth leading cause of non-communicable acute as well as chronic diseases in the United States. The most common causes of medication-related allergies are penicillin and other antibiotics, including amoxicillin, tetracycline, cephalosporin, and sulfa drug. Codeines and morphine, NSAIDs, aspirin, and as well as ACE inhibitors and anesthetic agent are also other common causes of allergic reaction. Up to 27 million people are allergic to penicillin. Penicillin as well as amoxicillin are responsible for 500 fatal cases of anaphylaxis each year, which accounts for an estimated 75% of all anaphylaxis death in the United States. Importantly, most death occurs amongst individuals with no history of drug allergies, so we must always be vigilant. Based on CDC, antibiotics are responsible for 1 in 6 emergency room visits for adverse drug events. In fact, antibiotics are involved in more emergency room visits than any other class of drugs in patients under 50 years of age. In children 5 or younger, antibodies causes more than half of estimated emergency department visit for adverse drug events. So why do we develop allergies? An allergy is a condition in which the body becomes hypersensitive to a particular antigen which provokes characteristic symptoms when they are subsequently inhaled, ingested, injected, or otherwise contacted. Normally, antibodies in the bloodstream and tissues react with and destroy a specific antigen without any further trouble. But in allergic situations, the body overreacts to that allergens. With that introduction, now let's explore various types of allergic reaction. There are 4 major types of allergic reaction that I like to review. Type 1 allergic reaction is anaphylactic reaction, creating an immediate reaction. This is an IgE-mediated reaction. Type 2 allergic reaction is a cytotoxic reaction, an IgG or IgM antibody-mediated reaction. Type 3 allergic reaction is an immune complex reaction. And type 4 allergic reaction is cell-mediated reaction, cells such as T cells or macrophages, and is a delayed allergic reaction. Type 1 allergic reaction, as I said, is an immediate type immune response, usually occurs within seconds or minutes after exposure to an allergen. However, it can also occur a couple of hours after exposure to an allergen, and sometimes it makes it difficult to diagnose. As I said earlier, type 1 antibody reaction are IgE antibody mediated in comparison with type 2, which is IgG and IgM antibody mediated reactions. What happens is that the allergens combine with IgE antibody that are attached to the mast cell as well as basophil and causes degranulation of the mast cell, shown here in purple. That degranulation causes release of inflammatory mediators such as histamine, bradykinin, leukotriene, thromboxane, prostaglandin, platelet aggregation factor, and interleukins. The allergens could be dust mites, pollen, animal dander, food such as eggs, nuts, milk, and shellfish, drugs such as antibiotics including penicillin, sulfa drugs, and cephalosporin, and even insect bites such as bee stings. The release of these mediators causes vascular dilation leading to hypotension, endothelial leakage leading to edema and a smooth muscle contraction causing bronchospasm. Example of type 1 allergic reactions are asthma, hay fever, allergic rhinitis, urticaria, angioedema, and generalized anaphylaxis. On the other hand, in type 2 allergic reaction, which is called cytotoxic reaction, an antibody-mediated immune reaction occurs. This is the result of combination of either IgG or IgM with an antigen that is present on the surface of or fixed to the surface of the cell membrane with subsequent complement fixation. Example of type 2 allergic reactions are drug-induced hemolytic anemia, idiopathic thrombocytopenia, blood transfusion reactions, and Rh incompatibility. It may take 6 hours or even longer, up to 36 hours, to see any reactions. Type 3 allergic reactions are also called immune complex reactions. In this type of reaction, antigen-antibody complex are deposited in the blood vessel or the tissue and cause inflammatory response and tissue damage. Such reactions may progress to immune complex diseases such as systemic lupus, rheumatoid arthritis, glomerulonephritis, and serum sickness. It may take 4 to 12 hours to see the reactions in type 3 allergic reaction. Type 4 allergic reaction are also called cell-mediated or delayed allergic reaction. A cell-mediated immunoreaction that is dependent on the presence of a significant number of primed antigen-specific T cells. It usually occurs 24 to 48 hours after exposure to an antigen. T cells, macrophages, and cytokines are involved in this type of reaction. Example of type 4 allergic reactions are poison ivy, contact allergy such as contact with nickel, graft versus host disease, and transplant rejection. Another example of infection type allergic reaction, which is exemplified by the tuberculin skin test, in which a person who has previously been exposed to Mycobacterium tuberculosis or TB develops a delayed response, usually within 48 to 72 hours after exposure to components of the bacteria. The response is characterized by induration, erythema, swelling, and sometimes ulceration at the site of injection. Remember, this type of allergic reaction is also type 4 allergic reaction. Type 1, 2, 3, and type 4 hypersensitivity reaction have been reported to a wide variety of material used in dental practice, including topical anesthesia, acrylic compounds, some mouthwashes, and toothpaste. Majority of allergic reaction related to dentistry includes mild symptoms such as skin rash from taking antibiotic and other medication. Now, going back to our patients that had a severe reaction to amoxicillin, I'm sure that you diagnosed that case as generalized anaphylaxis. And we know that anaphylaxis is a very serious medical emergency that can lead to an acute, life-threatening respiratory failure. As I said, medical emergencies related to allergic reactions are uncommon but possible in dental patients. Let's summarize the finding of generalized anaphylaxis. Patients may have sudden feeling of weakness, generalized flushing or itching, hives or rashes in any part of their body, rapid swelling of their throat, and tongue could also swell up. Then they are going to have difficulty breathing, speaking, and swallowing. Wheezing, nausea, vomiting, and abdominal cramp are other symptoms of generalized anaphylaxis. So anaphylaxis is type 1 allergic reaction as a result of antigen-antibody reaction, which leads to the release of mediators, as explained before, resulting in vasodilation, a smooth muscle spasm, increased vascular permeability, leading to edema formation. Now let's look at various organs and structures to see the clinical manifestations. In a skin, those manifestations may include swollen, red, itchy skin, rashes, hives or urticaria, angioedema of the face, tongue, lip, and or throat. Clinical manifestation in respiratory system may include bronchospasm, wheezing, cough, dyspnea, chest tightness, stridor, which is a high-pitched whistling sound, throat tightness, lumpiness in the throat, and hoarseness. Dysphagia, which is difficulty swallowing, and rhinorrhea or runny nose are amongst respiratory systems manifestation. Clinical manifestation in cardiovascular system, on the other hand, may include weakness, hypotension, lightheadedness, shock due to inadequate perfusion, and loss of consciousness. Clinical manifestation in the gastrointestinal system may include cramps, nausea, vomiting, and diarrhea. In other areas, patient may have sense of impending doom, metallic taste, and uterine contractions. Cause of death after anaphylaxis in majority of cases, about 70% of cases, is upper airway edema and airway blockage. 20% of cases may have circulatory collapse, and remaining 10% could be a combination of respiratory and circulatory issues. As far as emergency management of anaphylaxis, the most important step is recognition of allergic reaction. Then, of course, stop the procedure. Place the patient in a comfortable position. Recline the dental chair if hypotensive. Provide oxygen and continuously monitor the vital sign. The most important agent after oxygen is epinephrine. If you have epinephrine ampules, you have to withdraw 0.3 to 0.5 milliliter of epinephrine 1 to 1,000 concentration, which is equal to 0.3 to 0.5 milligram, and deliver that subcutaneously or inject it into in the IM route for adult. For children, the dosage is half of the adult. So it's epinephrine 1 to 1,000, 0.15 or 1500ths of milligram for children. If EpiPen is available, then you don't have to calculate anything. Use EpiPen 0.3 milligram for adult and 0.15 of milligram for children, and you can repeat that every 5 to 10 minutes. Benadryl or diphenylhydramine, when used, may cause drowsiness, nausea, and dryness of the mouth. Could be used after that. Remember, epinephrine is the main treatment for anaphylaxis, not antihistamine. One of the most recent and interesting auto-injectable devices is the talking auto epi injection, or AviQ. A little bit expensive, but very interesting device. As you continue to monitor the vital sign, start an IV line if trained to do so, and transport the patient to the hospital. Now let's look at what's the difference between a drug allergy and a pseudoallergy. A true allergy is an overcorrection of immune system to a foreign substance. It is an immune-mediated response. On the other hand, a pseudoallergy is not caused by a direct activation of the immune system. Instead, histamine is released directly from subcutaneous mast cell, but it mimics an allergic reaction. Examples of true allergies are generalized anaphylaxis, Stevens-Johnson syndrome, while examples of pseudoallergies are red man syndrome from vancomycin and rashes or hives after radio contrast media. I would like to emphasize that the drug allergies should only be referred to the reaction that are mediated by immunological mechanism. It should not include toxic, pharmacologic, or idiosyncratic reaction from drug overdose or a system malfunction. When you see a patient that claims he or she is allergic to a medication such as Tylenol, ibuprofen, aspirin, codeine, xylocaine, carbocaine, and Novocaine, which has not been used, Novocaine has not been used in dentistry for decades due to the high allergic reaction, but patient continues to call any local anesthetic used for them as Novocaine. Ask the patient to describe their reaction. Do they have sweating, fainting, lightheadedness, or heart palpitation? Do they have rashes, hives? Most often their explanation will give you a clear clue about their allergic reaction. This is a fundamental aspect of patient history and interview if you want to distinguish a true allergic reaction from a pseudo-allergic reaction or side effect. When a patient indicates he or she has had an allergic response to a medication or material, it is important to obtain all the important and relevant details. It may be necessary to contact previous providers to determine the substances that cause the allergic reaction, the extent of systemic involvement, and emergency treatment that was provided, if applicable, for that patient. The clinician should not proceed with any dental treatment if there is inadequate information about the patient's allergy history. Here are examples of a few questions that you can ask a patient and points to think about it. So the questions to ask are, how long ago did the reaction occur? Was it many, many years ago, during childhood, or last year, last month, last week, or was this morning? Have you ever had the same reaction with a different drug? How soon after the treatment or use of the medication did you have the reaction? Check the patient's emotional level of anxiety. Distinguish true allergic reaction from the drug side effect or even a reaction caused by inadvertent drug administration. After getting a local anesthesia, was the reaction just a fast heartbeat, or did you have rashes, hives, or any other symptom? That's an important question to ask the patient. The next question is how were you treated? Were you taken to the hospital? Did they use an EpiPen or epinephrine? Did they give you antihistamine, a steroid, oxygen, or a spirit of ammonia or a smelling salt? Or they didn't do any treatment and just the allergic reaction disappeared? Based on CDC, approximately 10% of all US patients reported of having an allergic reaction to a penicillin class antibiotic in their past. That includes penicillin, amoxicillin, and augmentin. However, many patients who report penicillin allergies do not have a true IgE-mediated reaction. When evaluated, fewer than 1% of the population are truly allergic to penicillin. Approximately 80% of penicillin with IgE-mediated penicillin allergies lose their sensitivity after 10 years. The important ramification of incorrect reporting of an allergy can mislead provider, resulting in modification of treatment. alternatives will be given, which may not have the same efficacy or therapeutic benefits, and many may be even more expensive or harmful in some cases. We know that there are cross-reactivity across some drugs with penicillin, such as cephalosporin. Most cephalosporin, especially in the later generation, can be safely tolerated despite a penicillin allergy. Amongst the first and second generation cephalosporin, such as cefazolin and cefoxitin, there is about 5% risk of cross-reactivity with penicillin. However, with the third and fourth generation cephalosporin, the risk is much lower, at less than 1%. Pediatric patients, children who are receiving amoxicillin or ampicillin and have Epstein-Barr virus infection, can develop a non-allergic, non-pruritic rash that can appear similar to an allergic reaction. How about allergic reaction to opioids? True allergies are rare. Codeine, morphine, meperidine, or Demerol are the ones reported to have majority of reaction. The most common reactions are itching, hallucination, which could be considered as a side effect. Now let's change the subject to urticaria and angioedema. Both of these are different manifestations of the same pathologic process. They can present together or separately. The estimated distribution is 50% urticaria alone, 40% together, and 10% of cases are angioedema alone. Urticaria, which is also called hives, is rather common. It is believed that 10 to 20% of the population will have at least one incidence of urticaria in their lifetime. Urticaria is due to localized edema of the superficial layer of the dermis. Clinically, it is well circumscribed veal, with raised erythematous border and sometimes a blanching center or a white center in the middle. It is often very pruritic and itchy. Individual hives can last from as brief as 30 minutes to as long as 36 hours. They can be as small as a millimeter to 6 to 8 inches in diameter in cases of giant urticaria. They blanch with pressure as the dilated blood vessels are compressed, which also accounts for the central pallor of the veals. Allergic urticaria is IgE antibody mediated. Food can trigger urticaria such as nuts, chocolate, mint, egg, tomato, fish, seafood, spices, food additive, and preservatives. Some cases of food induced urticaria is not IgE mediated reaction, but by substances that can directly act on mast cell or to release histamine and other mediators such as allergy to strawberries. Penicillin is the most common medication that can cause urticaria. However, urticaria can be caused by sulfa or aspirin and other medications such as opioids, ACE inhibitors, NSAIDs can also cause urticaria. Urticaria may occur on apparently non-immunological basis, such as urticaria related to heat, cold, vibration, pressure, sunlight, and emotion. Additionally, a number of medications such as aspirin and certain antibiotics such as ciprofloxacin and vancomycin can also cause urticaria by non-allergic mechanism rather than by IgE-mediated mechanism. Recurrent chronic urticaria is urticaria that is present for more than 6 weeks. Although this type of urticaria occasionally could be as a result of food or drug allergy, in majority of patients with chronic urticaria, no external causes or underlying disease process could be identified. It could be related to malignancies such as lymphoma, thyroid disease, vasculitis, collagen disease as well. Circulating antigen-antibody complexes are associated with recurrent chronic urticaria also. Diagnosis of urticaria is made by clinical presentation. Identification and elimination of the etiologic factor is the first step for treatment of urticaria. Benadryl or diphenylhydramine 50 mg, Atrax or hydroxyzine 25 to 100 mg can be given every 4 to 6 hours. Topical steroids are not usually effective. However, systemic steroids such as prednisone 40 to 60 mg a day are reserved for severe cases and only for short period of time. Angioedema is localized anaphylaxis of deeper blood vessel of dermis. It is characterized by recurrent non-pitting edematous swelling of subcutaneous or submucosal connective tissue of sudden onset. Patients with angioedema might present to our offices because of the swelling resembling a dental abscess. Clinically, it is usually easy to distinguish between these two. The swelling that is associated with angioedema is not painful and might also be associated with itching. However, sometimes a radiograph is needed for diagnosis to rule out dental abscesses if the swelling is only located on the lip. Angioedema often involves these structures: lip, either upper lip or lower lips, eyes, and face. However, it can affect other parts of the body, including hands and feet. If it occurs inside the mouth, it can involve the tongue. It can also extend to the pharynx, larynx, and respiratory tract and could be potentially dangerous and sometimes fatal. Angioedema of the gastrointestinal tract can lead to severe abdominal pain, nausea, vomiting, and diarrhea. Angioedema is classified into 4 groups: hereditary, acquired, allergic, and idiopathic angioedema. Hereditary angioedema is extremely rare. Allergic angioedema is IgE mediated as a result of mast cell degranulation. Angioedema can be triggered by drugs, food, plant, dust, and inhalant. However, it can be triggered by physical stimulation such as heat, cold, pressure, or vibration. The severe form of angioedema that occurs with the use of ACE inhibitors is not IgE mediated. In that case, is related to increased level of bradykinin and don't respond well to antihistamine. So let's talk about angiotensin converting enzyme or ACE inhibitors. Over 40 million are used in the United States, and it makes 35% of all prescribed medications for hypertension. There are other indications for use of ACE inhibitors, such as myocardial infarction, heart failure, systolic dysfunction, diabetes, chronic kidney diseases, to name just a few. Is the leading cause of drug-induced angioedema. 0.1 to 0.7% of induced angioedema are caused by ACE inhibitors. Angioedema-associated ACE inhibitors can occur with any types at any time and not dose-related. I personally have seen a patient, several patients actually, that they have been on lisinopril for many years and then they develop angioedema. And we have to be really alert about this drug. Diagnosis is based on clinical presentation. First, swelling and puffiness of the lip and the eyes, which is the hallmark of angioedema. Redness can accompany the swelling or may appear on its own. A rash which may appear as a small bump or flat areas clustered together can develop anywhere on the skin and is usually reddish in color. Treatment should be focused on identification and avoidance of the triggering factor, including certain food, medications, and drugs, as I said, such as ACE inhibitors, as well as NSAIDs. Most cases of angioedema, they get better without any treatment after a few days of cessation of the medication. It is rare to see patients in a dental practice with severe angioedema, but we have to be alert about this condition. Patients with moderate to severe angioedema often present to the emergency room, not to any dental practice. When we speak of treatment, the medication used is Benadryl 50 mg by mouth or in IV form every 6 hours. However, if Benadryl is not working, epinephrine 0.5 mg subcutaneously or 0.3 to 0.5 mg IV can be used, particularly if laryngeal edema is suspected. Second-generation antihistamines such as Zyrtec 20 mg or Claritin 10 mg could be used instead of Benadryl. But most important consideration is to stop taking the medication even if the patient has been taking it for several decades before allergic reaction is seen. Recently, fresh frozen plasma has been shown to substantially improve ACE inhibitor-related angioedema. Attenuated androgen, such as danazol or stanozol, can be used for prevention of attack in both hereditary and acquired angioedema. Next topic is contact dermatitis and contact allergy, which are type 4 cell-mediated reactions. These reactions occur 24 to 72 hours after contact exposure. When we speak about contact dermatitis and contact allergy, we have to get to know haptens. Haptens are small molecules that cause an immune response only when attached to a large carriers such as a protein. The carrier may be one that also does not provoke an immune response by itself. But when a hapten such as poison ivy, soap, detergent in the fabrics, nickels, rubber products, even penicillin, neomycin or sulfa combines with a host protein, it forms an allergen and causes a reaction. Clinically, in contact dermatitis, we can see a skin reaction, occasionally in form of vesicle formation or severe itching. Contact allergies are, however, relatively uncommon intraorally, but toothpaste, mouthwashes, candy, chewing gum, cinnamon can cause contact allergies in the mouth. Lesions that could occur are white, red, or ulcerative, and they look like lichen planus. We call them lichenoid reaction. Diagnosis of contact dermatitis is based on patient's history, clinical picture, and even patch test. Of course, avoidance to come into contact with those substances that cause allergy is the primary approach to prevention. But if there are dermatitis reaction, it is generally treated with local or systemic steroid. Over 6% of the general population are allergic to latex, and I'm one of them. Dentists and other healthcare workers are particularly at high risk for allergic reaction to latex. And for that reason, latex gloves and rubber dams are not used in most dental practices, and if you have it in your practice, get rid of them. Interestingly, Natural rubber latex is derived from a milky substance found in rubber trees. We develop allergy to the latex protein. The powder on the latex gloves can absorb the gloves' latex protein and cause increased exposure to latex. In addition, as the gloves are removed, the powder may become airborne, coming in contact with our eyes, nose, or mouth and act as an allergen. Clinical presentation of contact allergies include urticaria, rhinitis, eyelid edema, and even anaphylaxis. Now that we discussed about several other cases, let's look at our next patient. Our next case is a 25-year-old apprehensive patient who presents to the office for several restorative procedures, including crown prep and implant procedures. Patient is placed in the dental chair in reclined position. Topical anesthesia followed by local anesthetic are administered. Shortly after that, the patient starts gagging, coughing, and it seems that the patient has difficulty breathing. You notice a wheezing sound and a short but fast breathing. He tells you that he thinks he has heart palpitation, and you check his vital sign and his blood pressure is 163/98 and his heart rate is 142. He also tells you that he feels tightness in the chest as he cannot breathe well. You stop the procedure, upright the chair, and are thinking about your differential diagnosis. Could it be heart attack or stroke? But he has no history of cardiovascular issue that he knows. Maybe he is hypoglycemic or aspirated something. How about generalized anaphylaxis or an asthmatic attack? He does not seem to have a heart attack or a stroke, although that must still be in your mind, as heart attack or stroke could occur without known history of cardiovascular or cerebrovascular issues anyway. He has no body rashes or hives, no history of diabetes. You have not put anything in his mouth to aspirate, but that distinct sound of wheezing, coughing, and difficulty breathing points mostly to an asthmatic attack. What would you do next? Before we talk about that, let me explore some statistic about asthma. Asthma is a very serious global problem. The number of people with asthma have increased drastically in the last couple of decades and continues to expand. Based on the World Health Organization, or WHO, and CDC, it affects more than 339 million people worldwide. Over 25 million are currently affected in the United States. People with asthma also have higher chance of developing respiratory infection from a variety of infectious agents, including SARS-CoV-2, which causes COVID-19. Asthma primarily affects children. About 10% of children have asthma. In children, asthma is more common before 10 years of age and is more common in male than female. However, in adult, it is slightly more common among women than men. It is also more common in African American individuals. When we look at patients developing asthmatic attack, the numbers are impressive. Based on CDC, about 11 million asthmatic attack occurs each year. Of that, 1.5 million need to go to the emergency room every year, and about 180,000 are admitted for treatment. Unfortunately, the mortality rate have tripled in the past several decades. Each day, 10 Americans die from complication of severe asthmatic attack. That's over 3,500 people dying each year in the United States. And most death occurs in older adults. Asthma, by definition, is a chronic inflammatory disease of the airway with acute exacerbation. Physiologically, asthma is characterized by hyperresponsiveness of tracheobronchial tree to various stimuli. Clinically, it is manifested by paroxysmal dyspnea or spastic shortness of breath, chest tightness, and cough or wheezing. The lung tissues of an asthmatic patient is very sensitive to a variety of stimuli. Asthma can be provoked by different allergens, including upper respiratory infection, exercise, cold air, chemicals, smoking, food, gastroesophageal reflux or GERD, and certain medications such as ibuprofen and aspirin, which are imperative for us to know. Remember that higher emotional states such as stress and anxiety and nervousness, which may be anticipated by visiting our dental practices, can most certainly precipitate asthmatic attack. Asthma is a multifactorial disease. The exact etiology of asthma is not known at this time. Asthma is classified into 5 groups. Extrinsic asthma, which is also known as allergic or atopic asthma. Intrinsic asthma, which is also referred to an idiosyncratic or non-allergic asthma. Drug-induced is another type, and the next group of asthmatic asthma are exercise-induced, which we see a lot in our dental practices. And finally, infectious type of asthma. The first type of asthma that I'm going to talk about is allergic or extrinsic asthma. It is the most common form and accounts for about 35% of all cases. Pollen, dust, house mites, and animal danders usually triggers that. This type of asthma is IgE mediated, and there is a positive family history of allergic diseases such as an allergic rhinitis, asthma, and eczema. Combination of allergens with IgE antibodies located on the mast cell, as I explained before, causes release of mediators such as histamine, bradykinin, leukotrienes, and prostaglandins, and lead to bronchoconstriction, increased vascular permeability, smooth muscle contraction, and eosinophils attractions into the airway. The end result would be tissue edema and excessive mucus secretion. Intrinsic asthma accounts for 30% of asthma cases. In this type of asthma, there are no personal or family history of allergy. Patients have normal IgE level and negative skin tests too. Intrinsic asthma is seen in the middle-aged adults and is associated with endogenous factors such as emotional stress and gastroesophageal refluxes. Exercise-induced asthma is stimulated by exertional activities. Although the pathophysiological cause of that is unknown, but inhalation of cold air provokes mucosal irritation and airway hyperactivity. Children and young adults are more severely affected because of their high level of physical activities. In infectious asthma, patients develop bronchial constriction due to inflammatory response to infectious agents such as a virus, bacteria, or fungi. It is now recognized that several respiratory viral infections during infancy and childhood can result in the development of asthma. Asthma can be triggered by foods such as nuts, shellfish, strawberries, milk. Also medications such as aspirin and NSAID, beta blockers, angiotensin converting enzyme inhibitors, ACE inhibitor. Aspirin can cause bronchoconstriction in 10% of asthmatic patients. Sensitivity to aspirin occurs in 30 to 40% of patients with asthma who have pansinusitis and nasal polyp, the so-called triad asthmaticus. So you have to be really careful when you recommend aspirin or ibuprofen to an asthmatic patient, as it can trigger an asthma attack. Asthma is relatively benign in terms of morbidity. However, a small percentage of patients might develop emphysema or respiratory failure. The most serious form of asthma is called status asthmaticus. This is particularly severe and prolonged form of asthmatic attack that lasts more than 24 hours and is usually refractory to various type of medications. Means various type of medications, they don't work for them. This form of asthma could be fatal. The most common signs and symptoms of asthma includes wheezing, cough, excessive mucus production, chest tightness, tachycardia and tachypnea, nighttime dyspnea. There are few clinical signs that we can identify in patients who have asthma. Several studies have suggested reduced salivary flow and increased caries rate among patients with asthma. This is possibly related to the use of beta-adrenergic agonist that reduces salivary flow and leads to an increase in the numbers of lactobacillus and strep mutans, making patients more susceptible to caries. Inhaled corticosteroids also have been linked to periodontal issues such as increased gingivitis and oropharyngeal candidiasis. Asthma is usually diagnosed by a combination of physical examination, personal history, lab tests, and lung function tests. During physical exam, we look for different signs and symptoms of asthma such as wheezing, coughing, dyspnea, use of accessory muscle, and chest tightness. Taking a good history from all patients is a crucial step in preventing unexpected medical emergencies in dental practice. And they should include a personal and family history of allergic diseases and asthma. Pulmonary function tests are essential for the diagnosis and assessing the severity of asthma by spirometry in medicine. Asthma can be classified in 4 categories based on severity. It could be mild intermittent, mild persistent, moderate persistent, and severe persistent. Severity is based on age, frequency of symptoms, impairment of the lung function, and risk of attack. Patients with mild intermittent asthma usually have infrequent symptoms with rare incidences of bronchospasm. They do not usually require maintenance therapy, and their forced expiratory volume is usually more than 80%. Patients with mild persistent asthma have intermittent episode of asthma, requiring regular maintenance therapy, and their forced expiratory volume is also more than 80%. On the other hand, patients with moderate persistent asthma have daily symptoms. Exacerbation that affects activity might require adjustment of medications and occasional emergency care. Their forced expiratory volume is between 60 to 80%. Finally, patients with severe persistent asthma have continuous symptoms throughout the day, with frequent exacerbation, frequent nighttime symptoms, and limited physical activity. They require emergency hospitalization. Their forced expiratory volume is less than 60%. The first step in management of asthma is identification and avoidance of precipitating factors or triggering factors. The goal in treatment are to restore normal activity, normal pulmonary function, minimize the frequency and severity of an attack, control of the symptoms, and avoid adverse effect of medications. There are a variety of medications available to treat asthma, and the selection is based on the type and severity of asthma and whether it is used as prophylactic or treatment, meaning that if they are for long-term control or a quick relief. There are many medications used for treatment of asthma. A few examples include beta-adrenergic agonist, This form of medications comes in an inhaler form. It is a bronchodilator and is used for acute asthmatic attack. The majority of them are short-acting, such as albuterol, sold under the names of Ventolin or Proventil. Inhaled corticosteroids are the most effective anti-inflammatory medications currently available for treatment of persistent asthma. However, remember that this medication cannot be used for acute asthmatic attack. It is not a bronchodilator. Examples are Flovent and Nasonex. There are multiple other medications, include systemic corticosteroids, and as an alternative to steroid for patients with mild to moderate asthma, leukotriene receptor antagonists such as Zyflo, Singulair, and Accolade are also used. The latest medication used to treat asthma includes immunomodulators such as Dupixent and Nucala, and other medications such as Spiriva and Atrovent. Nucala is another medication that has been introduced and used lately. It is an add-on prescription medication for patients that are 6 and older with severe eosinophilic asthma. Nucala is not used to treat acute asthma and is injected monthly for patients with severe asthma. Some individual may tell you that they have a breathing machine or a nebulizer at home. It is a way to take inhaled medication. A nebulizer has a compressor that can create a mist of medication and the patient uses to inhale for 5 to 10 minutes. This way the medicine is directly transported to the patient's lung. The modification before and during dental treatment can minimize the likelihood of an asthmatic attack in the dental office. As far as the dental management of asthmatic patients is concerned, just like medical management, we obviously need to identify and avoid the precipitating factor. Instruct the patient to bring their own inhaler to every appointment. Use it prophylactically, particularly if they have moderate to severe asthma or history of a recent asthmatic attack. Have a short-acting inhaler such as albuterol available in the office as an emergency medication. At home, tell the patient to consider fluoride supplement to prevent caries. Also instruct the patient to rinse their mouth after inhaled corticosteroids and reinforce oral hygiene instruction in order to reduce chances of oropharyngeal candidiasis. As far as outpatient IV sedation and general anesthesia, I recommend a prophylactic treatment with albuterol if patient has recent attack or history of recurrent asthma prior to the procedure. Questions that you should ask before you start to treat an asthmatic patient is, what type of asthma do you have? Mild, moderate, or severe? Is it under control? What triggers your asthmatic attack? When was your last attack? How often do you have to use your inhaler? Was there any occasion that you needed to go to emergency room, and were you admitted to the hospital for care, and when was the due time of that hospitalization? Was it recent or many, many years ago? For mild to moderate asthmatic attack in a dental office, if the patient has his or her own inhaler, have it ready to use. Use albuterol or Proventil, shake it well, and ask the patient to take 1 to 2 deep inhalation. Hold it in their mouth for 5 to 10 seconds. For more severe attack, activate EMS first. Bring the patient to a comfortable sitting position, provide oxygen and inhaler. And in these situations, you may have to give 0.3 to 0.5 ml epinephrine of 1 to 1000 concentration subcutaneously or in IM injection. And that could be repeated every 15 to 20 minutes up to 3 doses. Alternatively, use EpiPen for adult with 0.3 milligram dose or EpiPen Junior, which is 0.15 milligram dose for younger patients. And of course, if needed, transport the patient to a hospital. It is recommended after injection of EpiPen, especially EpiPen Junior, to send the patient to a hospital. Consider late morning appointment for patient with history of nocturnal asthmatic attack. Use caution when you are using local anesthetic with epinephrine. And if patient has moderate to severe asthma, use local anesthetic without epinephrine. Beware of potential adverse reaction to aspirin and NSAIDs. Provide a stress-free environment. Consider using nitrous oxide or even IV sedation if you can provide IV sedation. Consider corticosteroid replacement for all patients that are on long-term steroid treatment and have adrenal suppression. Avoid use of macrolates antibiotics such as erythromycin if patient is taking theophylline or Theodore to avoid theophylline toxicity. Finally, I'd like to wrap up this section with another scenario, which is very common in pediatric dental offices. An 8-year-old apprehensive boy is being treated for a deciduous tooth extraction, but before you even begin to give the patient local anesthetic, he starts hyperventilating, breathing deeply and rapidly. He's extremely anxious and agitated. He tells his mom to tell you that his toes and fingers feel cold and tingling. He complains of chest pain and becomes lightheaded and dizzy. He has tachycardia with a heart rate of 180. Diagnosis in this case is easy for any dental professionals. Obviously, hyperventilation, which is abnormal loss of carbon dioxide. A respiratory problem triggered by stress and panic. Respiratory rate and depth exceeds the body's metabolic demand for oxygen and carbon dioxide. How would you manage this patient? First, you have to stop the procedure, obviously, if you have started it already. Place the patient in fully upright position. Remain calm and reassuring. Have the patient mimic your own slow breathing. For that reason, instruct the patient to breathe through the nose, hold their breath, and then exhale. Paper or plastic bag or use of a full face mask for patients to breathe into it is helpful to prevent the abnormal or excessive loss of carbon dioxide. But importantly, I have to stress, for hyperventilation cases, do not give patients oxygen, as oxygen is contraindicated in hyperventilation cases. Monitor vital sign, and once again, remember, oxygen is not recommended. If symptoms persisted, consider sedation. Activate EMS as needed. Transport the patient to the hospital if needed. Perform all future dental procedures using anxiety-reducing measures such as sedation in the office, or take the patient to an operating room and do all necessary procedure under general anesthesia. I hope this presentation was helpful and provide some guidance to understand how to manage asthmatic attack, how to look for angioedema, and many other conditions that we spoke about. Remember, allergic reactions or angioedema, asthma is not just limited to your patients. It could be affecting your family and yourself if you're taking any medications or you have a history of that. And you have to be prepared and make sure that all your staff are trained to deal with situations in case of emergency. Medical errors can be defined as the failure of a planned action to be completed as intended, or the use of wrong plan to achieve an aim. Again, if you're prepared for emergency, perchance emergencies cease to happen. Benjamin Franklin said it the best. Think about it. Are you prepared? By failing to prepare, you are preparing to fail, as he said. So I hope you like these presentations, and I look forward to continue this conversation in the next presentation that I would discuss with you. I look forward to having you guys as my guest, and I hope you enjoyed this part of the presentation. Stay safe, and I look forward to talking to you very soon.